Here in York, we were early adopters of enhanced recovery after surgery, or ERAS.
That's a suite of interventions designed to get patients up and about and recovered from their surgery as quickly as possible.
One of the key elements is intraoperative goal-directed fluid therapy, and we know this improves patient outcomes.
But we knew that there was a big gap as they were going back to the normal ward after surgery.
It's frustrating. You've got a patient there immediately after the operation looking very well, and then 2 or 3 days down the line, not looking well. We felt that that's almost certainly due to the patients receiving too much intravenous fluids during that time.
This is not a problem that just occurs in York Hospital itself. In fact, it probably happens in many other hospitals across both the National Health Service and in other countries as well.
We were fortunate to receive a grant from the Health Foundation to allow us to introduce an innovative, protocolized way of giving intravenous fluids in the post-operative period to try and improve patient outcomes.
Now, when a patient is scheduled for surgery, the first part of their journey is to attend the preoperative assessment clinic. Depending on how they're stratified in terms of the risk group, patients will be assigned to one of a number of different protocols that affects how they're cared for in the post-operative period. The medium risk group is the group where we thought we can really innovate. They need enhanced care, but not necessarily a critical care unit.
During surgery, when patients receive perioperative goal-directed fluid therapy, we know that the patients are euvolemic. That is, they have the right amount of blood circulating around their body. Our aim in the nurse-enhanced unit was to continue the type of advanced hemodynamic monitoring that they get intraoperatively on the ward. Historically, the only option on the ward has been to give fluid, and we don't know whether we're doing right or wrong. What our protocol allows is for the nurse to make an assessment of whether the patient actually needs fluid at that time, because what we do know is that if we give excessive intravenous fluids, we are doing the patients harm.
So if we could leave arterial lines in patients and take them to the nursing enhanced unit, we could use advanced monitoring to change their care.
You'll be in it in a minute if you stay there.
When we were first told that the patients would be coming back to us with arterial lines, we all felt a bit nervous.
We developed a training programme that included competencies on caring for the arterial lines and also hemodynamic monitoring, the running of vasopressors.
The training has been very comprehensive, and importantly, it's been nurse-led as well, so it's peer-to-peer learning, which is key.
And traditionally, on the ward, we've looked at pulse rates, blood pressure, urine output, which are relatively blunt tools, and often they won't become abnormal until the patient has deteriorated.
Now, in the first 24 hours post-operatively, the patient will have an arterial line with cardiac monitoring. So we're now able to utilise stroke volume as well.
They come with their fluids already prescribed. It gives us the opportunity to know when to give the fluids rather than waiting for the doctor to come. If the patient's stroke volume drops, it could mean that the organs are not being perfused properly, so we need to give the patient some more fluids.
You're able to detect problems earlier, and the earlier you're able to detect a problem, the easier it is to correct.
There's a new sense of independence on the ward, and patient comes back with the target ranges, so the nurses can now determine if a patient needs fluid rather than just giving the fluid and overloading.
It's been a shining example, I think, of multidisciplinary working between medical staff and the nursing staff.
By introducing these protocols, we've seen a reduction in the variability of fluid administration in the post-operative period. The amount of fluid has reduced significantly by about 1.5 litres. For the patients, that means a more standardised, predictable recovery.
Mean length of stay has reduced by 2 days, and median length of stay has reduced by 1.
Actually seeing the results in black and white, makes it all worthwhile, really.
I hope clinicians will just look at what we've done here and say, this is simple, it's straightforward. I can apply these protocols and principles to my patient group, ultimately improving their outcome and quality of care.